That is perfect timing. All right, so let me just get my papers here. So welcome to Grand Rounds, everyone. Again, I say this every time, but I just feel so grateful that all of you come to Grand Rounds. I think they are fantastic, and we have a fantastic rounds again today. I want to remind everyone we are at the end of our chair search. Dr. Nasia Saftar has been here this week, and next week our last candidate is Dr. Ann Dixon from University of Vermont, and she'll be here on Monday, Tuesday with her town hall on Monday at 5 p.m. So as all of you know, we have fantastic chief residents. And one of the things that they do as part of their job is they present grand rounds toward the end of their chief year. And these are, in my mind, usually some of the best grand rounds that we have. And I feel very humbled at the quality of the chief residents that we attract in this program. And so today we have Dr. Brian Lewis, who is going to be presenting grand rounds as one of our chiefs, and his title is Back to the Future, the Resurgence of Home-Based Primary Care. So a little bit about Dr. Lewis. He did his undergraduate degree at WashU at St. Louis. His medical degree was completed at Cleveland Clinic Lerner College of Medicine, Case Western Reserve. He came here then to do his residency, and he is now the Trowbridge Endowed Internal Medicine Primary Care Chief Resident. I'm very happy to say he's staying with us to do a fellowship in geriatrics, and we're very hopeful that he will join us on faculty here. Just a couple of things to highlight. He is on our Internal Medicine Residency Wellness Committee at University of Wisconsin. He's already done 2 national presentations in a paper during his time that he has been here during his residency. And I think something that speaks to the very core of who he is, our 3 awards he's achieved since he's been here in his residency. I think that Dr. Lewis, his humanism and kindness and compassion are known throughout our program. And last year, he received the dual honor of receiving the Larry Crocker Award, which is given to a medicine resident who demonstrates outstanding commitment to general medicine, and the Sunday Humanism Award, which was given to a resident who recognizes the importance of the human touch of medicine, and 2 years before received the Sobey Matthew Award, which really also talks to humanism and selflessness. So with that, Dr. Lewis, come on up.
I'd like to start out today with a personal story. Show of hands, how many of you recognize this fictional TV doctor behind you? So for me, this is associated with a childhood memory. When I was a kid, homesick, there were 3 things that I could guarantee. 1, that I could stay in my Teenage Mutant Ninja Turtle pajamas for longer that day. 2, that I would likely be watching Little House on the Prairie with my mom, who loved that show. And 3, I'd likely be going to the pediatrician's office, likely to get some bubblegum amoxicillin for what was likely a viral ear infection. One day, I asked my mom, when we were watching this show, why couldn't the doctor come see me at home? I was sick. I didn't want to go outside. And my mom just said, that's just something doctors don't do. So, fast forward, I'm in medical school, and if you would ask me what I'd be doing right now, I would never tell you that I'd be a chief resident giving grand rounds. And ironically, I would tell you that there was no way that I'd be doing a geriatrics fellowship. I thought I was going to go into GI. I did a whole year of research on inflammatory bowel disease in med school, but it wasn't until a required geriatrics elective as a third-year med student where I found my love for geriatrics. And in particular, during that month, I was able to do a week with a home-based primary care team at the Cleveland Clinic. And there, for the first time since I was a kid, I could see that physicians did go to the home. You could provide excellent primary care in the home. And so when coming up with what I was going to talk about for my grand rounds, it was pretty easy. This is something that not only changed the career trajectory of myself, but something that I'm very passionate about. So I'm hopeful that today I'll be able to share a piece of that with you. I have no relevant financial disclosures. All right. So here's what I hope you all get out of this talk today. One, I want you to leave here being able to define what home-based primary care is. Second, I want you guys to recognize home-based primary care as an effective mode of delivery of primary care, and that it is likely going to become more important given our aging population. I want you to understand the importance, as with all medicine today, that it's no longer a solo practice. There's no longer Doc Baker going out by himself to do home visits. This is a multidisciplinary team that is required to deliver effective primary care. And lastly, I hope to impart the importance of educating our learners at all levels within medical education about home-based primary care. To get there, I'm going to spend a little bit of time talking about the history of home-based primary care. I'm going to spend some time defining what it is. We'll go over some of the current models out there today, and then we'll also spend a little bit of time about education, and I'll end on some new developments with home-based primary care at UW. This photo is called The Doctor by Sir Luke Fields. This is what you think of when you think of medicine prior to the early 20th century. Someone fetching the doctor, them going out into the home and delivering care. In fact, up until the 1940s, 40% of all medical care was done in the home. By 1950, that percentage had dropped to just 10%. And by 1980, that percentage had dropped to just 1%. So much so that in the mid-90s, there was a New England Journal of Medicine article entitled "House Calls to the Elderly, a Vanishing Practice Among Physicians." And between the years of 1988 and 1993, we saw a further decline in home visits and home-based primary care. And in 1996, there were only 984,000 visits billed through Medicare for home visits. Now, why is this? There was some thought that with the technological advances being made with labs and imaging, that you couldn't provide the same level of care in the home that you could in the clinic. In the clinic, you had everything available to you, particularly with the electronic medical record. However, the other thing was, and this is likely the most important thing that drove the decline in house calls, is that Medicare reimbursement was not great. You couldn't get reimbursed very much for doing a home visit. However, in 1998, Medicare changed its billing and coding and actually increased the reimbursement for Medicare home visits by about 50%. And in doing so, home-based primary care started to pick back up, to the point where when you're looking at Medicare data from 2015, there was about 2.6 million home visits billed for that year. So as you can see, through some changes as well as some further technological advances, which I'll get into later in this talk, we were able to have a resurgence of home-based primary care. Now to get to the nitty-gritty details of what home-based primary care is. But before I do that, I wanted to start out with a case. For all the primary care providers out in the audience, we all have a Mr. R in our panel. For me, Mr. R, 85-year-old male, had a history of cabbage, hypertension, diabetes, AFib on warfarin, severe osteoarthritis of his knee, used a walker, and he would see me in clinic quite often. However, a year ago, unfortunately, his wife passed away, and he had missed the last 5 follow-up appointments with me. Despite reaching out and talking with our case management to try to see if there were any resources he needed, he continued to not show up in clinic. I would only see what happened to him through the notes that I would get CC'd in the chart. He would get sent to the ED because he had a mechanical fall at home. He would get sent to the ED and admitted for a heart failure exacerbation, or he would go into AFib with RVR. So I want you all to think about Mr. R as we talk about home-based primary care. I want you all to think about your own Mr. R for those primary care providers and how someone like this may benefit from home-based primary care. All right, so what is home-based primary care? There's a lot of healthcare that can be done in the home. One of the things that people are probably most common with or know about is Medicare home health. This is what we send patients home with after discharge of the hospital. It gets them physical therapy, it gets them speech therapy. And while this is a very important piece, and home-based primary care needs to work with home health agencies to help deliver effective primary care, this won't be the focus of the talk today. You're also all probably well aware of palliative care and hospice at home. And while this also is a very important piece of delivering effective care at home, my focus today is going to be solely on home-based primary care. And a key point I want to make here is that we also have additional ancillary services that help provide care in home. There's home diagnostic services, home laboratory, mobile radiology units. Now our patients can have their medications bubble wrapped and sent to them at home. And there's also some subspecialty services that actually still do some home visits. And so the key point that I want to make clear today is that for home-based primary care to work, you need a whole team. You need to work with all of the home health agencies and with palliative and care and hospice to provide all the care that these patients need. So to get a little bit more into home-based primary care, I think one of the common things that people get confused about is the difference between home-based primary care and Medicare home health. And so while they're all done in the home, there are some differences. Home-based primary care focuses on chronic disease management. It focuses on delivering longitudinal, comprehensive primary care, and you don't need a skilled need to get this. Whereas home health focuses more on problem-focused, acute hospital discharge conditions. It does require a skilled need, which is why you have to certify for physical therapy or occupational therapy. And I think one of the main points I really do want to hammer home today is that home-based primary care does not require a patient to be homebound in order to bill Medicare for this, whereas home health does require the patient to be homebound. This is a common misconception about home-based primary care, and I do want to make it clear that even though our patients who are homebound are likely to be the ones that will most benefit from home-based primary care, it is not a requirement. So just for those of you who aren't familiar, we'll get into a little bit of what Medicare defines as homebound. And while I definitely shorten this because it's a very much longer definition, the main point is you do have to have both criteria being met. One, the patient would need either supportive devices or assistance with mobility getting in and out of the home. Or they would have to have a condition that would be medically contraindicated to leave the home. And criteria two is they'd have to have a normal inability to leave the home. And in doing this, I want to be clear, they can still leave the home to go to other medical appointments. If they needed dialysis, they could still do that. They could attend religious services. We're talking about basically they're able to just get out of the home and go on vacation and routinely make a bunch of errands without a lot of assistance. And the last thing that is required is that leaving the home must require a considerable and taxing effort. And so, again, while a patient who meets this criteria would likely benefit the most from home-based primary care, it is not required. So I'm telling you that it's not required, but then who does qualify for home-based primary care? Well, if they meet the homebound definition, they definitely do. But in order to bill Medicare, you could actually cite the need to evaluate the home environment. So if we're considering Mr. R, if he did not meet homebound criteria, I could say that I need to go assess him in his home to evaluate his home environment, given his repeated mechanical falls, and Medicare would accept that. You can also cite the need to meet with caregivers in the home to assess their caregiver situation. And of course, you can always do a home visit if they're at the end of life, or if the patient has cognitive or psychiatric comorbidities that make coming to the office unfeasible. Two things, though, that Medicare will not reimburse you for a home visit would be patient transportation, because we have other methods and resources for them. So patient transportation and lack of transportation alone will not get you there. And pure patient convenience. So you can't just say, for patient's convenience, I went to do a home visit. You do have to document one of these reasons. So, to step back a little bit, what does a home-based primary care visit look like compared to a normal outpatient clinic visit? And I think the main point I want to emphasize is that the components are exactly the same. So in the clinic, when I would see Mr. R, we would do vitals. We would do a med rec. I would sit and talk to him about how everything was going. I would then go over our assessment and plan for all of his comorbidities. And I can still do the exact same thing, but in his home. But one of the key pieces that I did want to mention is that it is a privilege for us as providers to evaluate our patients in their home. I don't know about you all, but I don't think I would want my physician to be in my home all the time. I feel like I would probably hire a cleaner and be so worried about what they think of my home that I probably just would never let it happen. So I am always aware of this when doing a home visit. So for Mr. R, when I saw him, if you look over all the pharmacy med recs for him, he always said, I take every single medication I'm supposed to take. But when I saw him in his home, he had a bag of 35 pill bottles, some of which were numerous inappropriate doses of Lasix, unfinished antibiotic courses, different dosages of beta blockers. And when I asked him what he was taking, he told me that he would just try to grab the bottles that were on the top because he assumed that those were probably the ones he should be taking, which instinctively I knew that he wasn't taking his meds appropriately given that he kept getting readmitted for heart failure and AFib. But seeing it in his home was pretty enlightening. Additionally, while this is not a picture of his home, I was able to do a home safety evaluation and recommend some rearrangements to be done. I was able to actually get occupational therapy to come in and put grab bars in his shower and give him a raised toilet seat, because that's where actually most of his falls had been occurring. And I was able to do so because I was able to evaluate him in his home environment. So like I said earlier, that technology was actually a barrier and likely contributed to the decline in home-based visits and home visits in the early 90s. Now, technology has advanced so where we can provide the same level of care in the home. In addition to mobile lab services and radiology, you can now get a 1-lead EKG on a smartphone. The last smartphone I bought, I could check my pulse ox on it. And I actually did, out of curiosity, check it against our pulse ox in the clinic, and it was accurate. With the electronic medical record, with my cell phone, I can create a mobile hotspot, and I have access to their records, just like I would in clinic. And so what I want to emphasize is now we have so many advancements in mobile technology that technology is no longer a barrier for taking care of our patients in the home. When I did talk to Mr. R, I did try to get his perspective on why he didn't follow up with me in clinic. And he says, well, Doc, let me tell you what it's like. He said, the last time I saw you in clinic, I had to walk all the way and get to clinic. He drove, but he had to get to clinic. I needed labs because I was making changes in his diuretics and I wanted to check his kidney function. But unfortunately, the lab was closed by the time we finished our appointment. So he'd go back home and he would have to come all the way back the next day to get labs. And he said, sometimes I just didn't feel like doing that. He was also supposed to be in physical therapy at Research Park to help with his knee osteoarthritis. And he was like, that's another trip. And with him using a walker without his wife to assist him, who I sure found out how much care she did provide him when I went to see him, he said, sometimes I just don't feel like doing it because it's too much of a hassle and I'm afraid I'm going to fall. And lastly, he said then he had to go and pick up any new medication prescriptions from his pharmacy. And so he said sometimes it just wasn't worth the hassle. And so he didn't come see me in the outpatient setting because he said all of these things contributed to that, and that actually the only reason he went and sought care was when his symptoms worsened enough to require emergency care or to go be admitted to the inpatient. So think about your own Mr. R, and I will tell you that his story is not uncommon. And in fact, his story is going to probably become more common. As you can see here, our population is aging. And by 2050, the number of people in the United States who are going to be above the age 65, and particularly above the age 85, is expected to grow as the baby boomers age. So Mr. R's story is going to become more common. For those of you who like to see numbers instead of graphs, to hammer this point home, 1 in 5 people by 2030 will be 65 or older. And by 2040, 1 in 8 will be above 75. And within this population, there are going to be a significant amount of them who are going to be homebound and be like Mr. R. For instance, the last bit of data I saw on this was all the way back in 2011, which is 9 years ago now, or 8 years ago now, where there was an estimated 2 million homebound adults over the age 65 in the home. And there was an estimated 1 million people who were home limited, meaning that while they didn't meet Medicare's definition of homebound, they were still going to have difficulty getting in and out of the home. So I can only imagine how many more homebound adults we're going to have in the next 20 to 30 years. And we're going to need to find a way to address their care needs and provide them greater access to care. And so while I know that not all of you here in the audience are going to be primary care doctors or geriatricians or even do home-based primary care, this is going to affect everyone. For the subspecialists who are particularly cardiology, who have patients who are managing their heart failure, for the hospitalists who always has Mr. R's coming in and out of their hospital, this is going to affect all of us, which is why this talk is relevant to every one of you here. All right, so hopefully now you have a little better understanding of what home-based primary care is and why it's going to be important. I'm going to spend a little bit of time now talking about current models of home-based primary care and some outcomes. And I would be remiss if I did not mention the VA in talking about home-based primary care, because the VA has been ahead of the curve. And you can see from the chart behind me that they've had to think about this a little sooner. Between 2000 and 2010, the veteran population above 85 grew by 140%. And so the VA's had to think about how do we address the care needs of these patients sooner than outside the VA system. And so this actually was started in the 1970s at 6 institutions and eventually evolved into what their home-based primary care team looks like today. And one of the things that I want to mention is all the things that I use to define what home-based primary care is what the VA does to deliver home-based primary care to vets. It's a multidisciplinary team. They go out and reach out to the chronically ill vets that actually create a significant portion of the total cost for the VA in terms of medical care for their patients. And so since this has been going on for a while, we have a little bit of data to show the impact of what home-based primary care can have. In 2002, they looked at some data on whether or not utilization of hospital and nursing home services declined after starting home-based primary care. And as you can see here, very clearly, the number of hospital bed days of care, or time spent in the hospital and the nursing home, decreased by 63% and 88% respectively. And unsurprisingly, there was an increase in home care visits. Did this translate into cost savings? So what you see here is the average cost per patient per year. So before home-based primary care, the average total cost of VA care per patient per year was $38,168 in this population. And during home-based primary care, that cost decreased to $29,136, a 24% change. Now, this was largely driven, as you can see here, by decreased inpatient admissions and hospital time, decreased nursing home time. But do know that the home-based primary care visits did cost some money, and so actually in this analysis, the home care probably cost about the same as the inpatient care savings did, but we still had a net savings. They did another round of evaluation in 2007 to see if these things still held true. And you can see that there was a decrease in hospital admissions and the time spent in the hospital, as well as nursing home admissions and time spent in the nursing home. So, home-based primary care is able to allow these veterans to stay in their home and spend less time in the hospital. And while I don't get into it here today, one of the big questions when these studies came out was, well, the VA saved money, but did we just shift these costs to Medicare? And while I don't get into this study here today, they did analysis and actually showed that the VA home-based primary care actually saved both the VA and Medicare money, and that the costs were just not shifted to Medicare. So overall, the VA home-based primary care showed that there was a decrease in inpatient and hospital days in the hospital and nursing homes. It actually decreased the 30-day readmission rate. It was cost-saving. But more importantly, what did veterans think about this? And actually, veteran satisfaction was about 83% of the vets rated this as very good or excellent, which is one of the highest rated satisfaction surveys in the VA. And just to hit this point home, here are some quotes from veterans. And while I'm not going to read them to you verbatim, what I will say is that the general sense is that the vets express great appreciation for the care they receive in their home by the home-based primary care team. They're able to remain in their homes, not go to the ED as often, not be admitted. And from their perspective, as well as their caregiver's perspective, they're able to stay in the home much longer than they thought they would be able to. Many thought that they might be headed straight for a nursing home, but with home-based primary care, they were able to stay at home longer. So, I just told you about the VA, which has one of the long-standing home-based primary care teams in the country. But what about outside the VA? What has been done in terms of research there? I can say not a whole lot. There are a few small studies that looked at home-based primary care outside of the VA system, and I'm not going to go into all the details of those studies today, but typically the trend was the same as it was with the VA, that there was some decrease in hospital admissions, decrease in emergency department visits, and that likely it was going to eventually lead to some cost savings. But what I did want to spend time with you today was to talk to you about the Independence at Home Act of 2010. So this was signed into legislation by President Obama in 2010. Basically, it was set up to be very similar to VA home-based primary care, but it was designed to test a different incentive payment plan through Medicare. And what I mean by that is they, out of hundreds of applicants, selected about 18 practices who had experience in delivering home-based primary care. And they ended up calculating how much they expected to spend for these patients who their target patient were very chronically ill, high cost to Medicare. And so Medicare said, this is how much we expect them to cost. If you can get the cost below this number, we'll take the first 5% and the rest of the cost savings would be shared on and given back to these practices. So this was mainly a demonstration of whether or not a shift from a fee-for-service payment structure to more of an outcome and value-based structure would work. And also if it would work with giving these patients care in their home. And so what I can share with you is that this demonstration was originally supposed to be for 3 years. They extended it in 2015 for an additional 3 years. And then they extended it last year for an additional 2. So, and I'm going to go over a little bit of that data with you. Now, just, you can see from Medicare's standpoint that they want to decrease cost. But they did also have some quality metrics in there to make sure that the quality of care and the outcomes in these patients were also still good. This is just a map showing you where these patients, these practices are who are participating in the Independence at Home demonstration. Most of them are strewn along the East Coast, but all of these practices are they've had experience in home-based primary care. They're relatively small. Each year they were only allowed to enroll 200 Medicare beneficiaries per practice. And this is some of the quality measures now that they were able to include. So in addition to trying to reduce cost, Medicare had stated that basically about at least 50% of their patients had to have a discharge follow-up, whether they were discharged from the hospital. And 50% of those patients had to have a med-rec completed within 48 hours of that discharge. And that there should be some annual documentation of patient preferences of what their goals of care were. Additionally, the other quality metrics that they were using was that they were supposed to hopefully decrease all-cause hospital readmissions, hospital admissions, as well as emergency department visits, particularly for those things that could be managed in the outpatient setting. So like Mr. R, all of those things I could have tried to manage in the outpatient setting, and he didn't, but unfortunately, given the fact that he was lost to follow-up for a while, he ended up having to be admitted to the hospital and readmitted. And so the practices who are involved in this demonstration have to meet at least 3 of these 6 quality metrics in order to receive the incentive payment and the cost savings. So what did it show? They only have analyzed the first 3 years of data. And similar to the VA, they showed a decreased ED visits by about 8.4%. They decreased hospital admissions and readmissions by about the same amount. And this was all done at least by year 3. Did this translate into any cost savings? As you can see here from this chart, just to orient you, the top number there is savings per beneficiary per month, and on average of the first 3 years of the demonstration, it saved about $111 a month per beneficiary. However, if you look at that 90% confidence interval, none of this is statistically significant. And I think there are a couple of reasons for that. One, this study has just a very small amount of home-based primary care practices in the country. This was never something that was designed to actually be able to be generalized to home-based primary care throughout the country as a whole, or compare home-based primary care to outpatient medicine in the clinic. It was only designed to see if this new payment structure could basically reduce Medicare costs, and if it can also help improve quality outcomes in patients. So it wasn't really designed to be a study making a broad statement about home-based primary care. However, when you look at the report to Congress, everyone is assuming and is hopeful that with more years of data, will actually have some statistical significance with this, which is why this demonstration was extended for additional 5 years. So while not as strong of data as what I showed you for the VA, we still have some hope that this is also going to be demonstrated outside of the VA relatively soon. So what was it? When they actually looked at the individual practices, if you actually look here, only about 5 practices actually met the quality metrics and actually received the incentive payment within the first 3 years. And so likely one of the best ways to try to figure out what they're doing right was to look at what they were doing. And so when they analyzed the practices who were succeeding at these outcomes, they noted that they had frequent in-home visits, that they had reliable weekend and night coverage, so that if a patient called on Friday night, there was someone available to triage over the phone, and there was someone available over the weekend to go see them to avoid that ED visit and likely inpatient admission. These practices had some of the strongest ongoing community relationships. Like I said earlier, this is a team-based approach to have success for home-based primary care, and these practices were actively engaged in their community to help provide better care for these patients. And they also would frequently reevaluate their practices and try to find ways to improve. And so they're hopeful to take some of the best practices from these practices in the Independence at Home demonstration and share those with the other practices to see if we can get some data to support that not only can we lower cost, but provide better outcomes. All right, I'm going to shift gears a little bit here and talk about teaching about home-based primary care and why it's important. In 2016, there was a study done that showed that 2% of primary care providers account for 70% of all house calls. That roughly equates to about 5,000 primary care physicians. So while there are people out there doing house call visits, there's a lot that aren't. And one could argue that this is something that is lacking in our medical training. And that if someone had exposure to this early on, they might feel more comfortable doing home visits. When you look at residency education, home visits are more prevalent within family medicine. And at this time, at least in 2001, only 25% of internal medicine residencies had some sort of home visit experience. And I now recognize, after doing a lot of areas of study within this topic, that I was very fortunate as a med student to have any exposure at all to home-based primary care. On a fun side note, I am well aware that apparently this photo is blown up somewhere in the med school. I frequently get texts from med students and residents. I've never personally went to see it, but apparently in the med school somewhere on the 3rd floor, this photo is hanging up. In addition to the importance of teaching home-based primary care, I can say that there's some really good education innovation happening within regards to how we teach this effectively. Because I can tell you there are some barriers. Doing home visits requires an attending physician to be able to go out with their learners into the home, and with our busy schedules, it's sometimes not realistic. So a lot of the ways which programs are currently doing education and teaching, they're combining some didactic learning experiences with, of course, supervised home visits. But some of the more interesting things are having medical students and learners complete an OSCE on a video game to show as they walk through a house that was created in a fake house created in a video game, to see if they can identify all the safety hazards for their patients. With some of the more established home-based primary care programs in the country, there's now some evidence that some subspecialists are also incorporating some home visits into their care to help reach their patients. And one of the things that I've been thinking of is how can we use technology even more? My wife, who is here in the audience, can attest that I tend to buy a lot of techie things mostly just because I want them. But one of the, not because I definitely need them, and unfortunately they sometimes do just sit on the side of my nightstand collecting dust. But one of the things that I was really happy about buying a few years ago was a virtual reality set, because the 10-year-old inside of me got super excited. When I first received this, I noticed realtors are now doing virtual open houses with VR. So my thinking was, could we not utilize this technology and actually walk our learners through a home visit, particularly in doing a home safety eval, using virtual reality? So this is something that I'm very interested in and continuing to think about. But I think the main point I wanted to make was there are some really innovative ways to teach home visits that are coming through the pipeline. In my own experience here at UW, as a resident, I was fortunate enough to take part of the Teach Pathway. And part of my capstone experience here was to create a home visit experience for our learners, particularly our residents in the primary care track. And so what I did was I basically created some didactic teaching. I actually found a video computer-based simulation of doing a home safety assessment, and I sat down with my learners and went through all of this before they accompanied me or Dr. DiTallo in the geriatrics department on a home visit. And I basically asked them before and after the home visit teaching whether or not they felt that their confidence in identifying patients who would qualify for home visits went up, whether or not they felt comfortable doing a comprehensive geriatric evaluation in the home, whether they were comfortable doing a home safety evaluation, and whether or not they felt more comfort in identifying community resources. And while I'll say the N of this graph here is very small, it's about up to 10 people now, and I haven't run any statistics on it, but I did want to share with you all that this has been a project of mine since my intern year of residency, and so I'm very happy to be able to share that experience here today with you all. And so at least we're working on providing a home-based care experience for our learners. Lastly, I would like to spend a little bit of time going over home-based primary care here at UW. So in 2016, there were a total of 780 home visits done at UW. There was about half of them being home visits and about another half being to assisted living facilities. And about 75 MDs and 12 advanced practice providers did these home visits. And this is excellent, but a lot of times providers are doing this at the end of their day. They're adding on these patients at the end of their schedule. So it does take a toll on what we're able to do. And while I have been given permission to announce this, I am very excited to say that UW, in the fall of 2019, will have a dedicated home-based primary care team. The details are still being fleshed out. The process for referrals are still being worked out as well. But this represents a multi-departmental collaboration between geriatrics, GIM, family medicine, palliative care, population health. And so UW will now be able to provide home-based primary care to some of our patients, which is something that we did not have before. Dr. Melissa DiTallo will be serving as the medical director for this, and I will say that I will be working with her as a geriatric fellow to try to incorporate learning opportunities for all of our learners. So, more of this to come. So, in conclusion, I hope you all were able to see today that home-based primary care allows for greater access to care, and this will be particularly important given our aging population. I want you to see, hopefully, that home-based primary care is distinct from Medicare home health, and that you're able to define what it is now. I hope I have shown you that home-based primary care has the potential and has been shown in some systems to reduce ED visits and hospital admissions, as well as admissions to nursing homes. And that to be successful, it is definitely a team-based approach that we're already doing in the rest of medicine. And hopefully you can agree with me that teaching about home-based primary care within the medical education system is going to be important, even if not more important in the future, given our aging population. So what I would say in conclusion is that hopefully we'll be able to borrow from our home-based primary care practices of the past, combined with the technological advances that we've been able to have a beautiful resurgence of home-based primary care today, to hopefully help us solve our problems of care for providing fantastic care to our aging population in the future. Thank you very much. I do want to acknowledge a few people, particularly my wife, who's been supportive and very patient with me while I've been working on this talk, while also finishing my first 2 weeks of attending on UW inpatient wards. So she has been very patient, and I'm very appreciative of that. I want to thank my co-chiefs, because I can't imagine getting through this year without the three of you. So it has been a fantastic, fun year that's not over yet. Almost, but not quite. And then, of course, to all my mentors listed here who have been able to help me not only in my medical education, but particularly in regards to my projects here with home-based primary care. And with that, thank you for your attention, and I will take any questions.
Fantastic. Dr. Lewis will take his questions.
Yes.
We didn't hear much of the nuts and bolts about who goes out to these patients and who is their practice and physician assistant. Is it really the physician themselves? In this age where we have to practice at the highest level of our license, I would think that it would be reasonable to have a physician in a control center with nurse practitioners, physician assistants divided up into the city with GoPros on so that they can transmit this to the attending physician, as well as robotic vehicles that could take them from one place to another so that they could do their charting while in transit.
Yes, the question / comment was about the nuts and bolts of kind of who does these visits. I will say at the VA, this is mostly done by MPs and advanced practice providers. In some of the home-based primary care practices outside of the VA system, there is usually a combination of MDs and advanced practice providers that do most of the care. What I've seen work in some of the studies that I looked at in the literature, there might be an MD that goes out for that initial visit to do a comprehensive geriatric assessment in the home, and then the subsequent follow-up visits are done by advanced practice providers so that everyone is working to their level to provide care for all of these patients. Dr. Carnes.
That was a great presentation. So I was curious, in terms of legal protection, so you may have a male physician going and seeing an older woman with some cognitive impairment. She claims that the patient was doing something or something else. What kind of legal protections do you have for the physician?
That's an excellent question. The question was, what kind of legal protections do we have for the physician since we're going out into patients' home environments? What I would say is that when the liability and safety has always been a concern with doing home-based primary care, what I found is that there actually has not been any evidence of basically poor safety or any incidents that were documented that went to legal cases in terms of safety for patients. What I would say is that usually the protections that I've seen in the programs that are currently up and running are as follows, is that there usually is a lot of background work done before entering that patient's home in terms of figuring out not only do they qualify for a home visit, but is it going to be safe and appropriate for someone to go into that home? And so I would say a lot of the protections are done by doing the background stuff before we even send somebody there, because there are definitely patients where it is felt that it's not safe for them to go into the home. And I remember being told always, when I've been working with home-based primary care teams, that at any point if we felt unsafe, that we could leave the home. And typically most home-based primary care teams, while there are definitely some instances where there will be a solo provider going into the home, there always is typically, as much as possible, that there would be at least one or two people there for some protection. But I will say it is a valid point and concern, but I think a lot of that can be addressed with doing your homework basically before you go into the home. Yes?
There are data showing that graduates of osteopathic medicine schools are more inclined to go into primary care than MD schools. Are there any comparative data in terms of home-based clinical care between osteopathic physicians and allopathic?
The question was, there's some data to support that osteopathic medicine trainees are more likely to go into primary care, and is there any correlation or evidence for that they're more likely to do home visits as well? I will say in the literature search that I did, I wasn't able to come across any of the data specifically looking at osteopathic medicine. I will say that family medicine residents are much more likely to do a home visit and be more comfortable doing home visits than their counterparts in internal medicine, mostly because a lot of family medicine programs actually have it as a requirement that they do a home visit compared to our medicine programs. But I didn't see anything in particular about osteopathic medicine. Dr. Sikowski.
You know, when I was a medical student, I had the opportunity to do a home visit on a geriatrics rotation, and I still remember that visit to this day. So I'm so glad you had that experience too. But my question really is about the satisfaction of the team in taking care of patients in their home versus in the clinic, because certainly there's other challenges to home visits.
Yes, the question was about whether the satisfaction of the team taking care of patients at home. I didn't get into it in this talk, but what I'll say is there is a little bit of evidence in the literature that while there are some logistical issues with taking care of patients in the home, that for those who do full home-based primary care, instead of not just added on to like a full clinic day and then you go out and do a home visit, but for those who are involved in a full home-based primary care team, that actually the providers find that very rewarding, and that it actually is something that helps reduce the likelihood of burnout compared to just being in the office. Because I will say, I have seen personally when I've gone in to do these home visits, I find it very rewarding and satisfying to do, and I find primary care in the office very rewarding too. But I think being able to go into a patient's home and provide them the care that they need is a very rewarding experience, and I do think it helps. We'll probably have further studies on it, but that it does help prevent burnout among physicians. In the back.
A lot of attention is given to the caregivers, like medical providers, and I feel that a lot of other players in this game, I think society stands to benefit. And obviously, people were not doing long-term facilities, it's a huge cost savings. Where do you think other players should be putting their efforts and investments in the home-based primary care, because it's not expected only the medical providers to produce the entire thing.
The question was, where should other players be involved in trying to kind of promote home-based primary care, because this shouldn't always all be just on the provider. And I agree with that statement that this, as I tried to emphasize in my talk, that this is definitely a community and team-based approach, and that in order to deliver this effective care, you need to involve like home health agencies and other community resources. I would honestly say that while we'd be able to set up primary care from a provider standpoint in the home, a lot of emphasis in building up community resources within an area to provide resources for the physicians to utilize, such as, I think when I've done home visits here, we've utilized the Madison Coalition for the Blind, we've utilized resources for like Meals on Wheels, we've utilized other community-based resources, and I think that is an area that probably needs to be bolstered up in order to help provide the care to our patients who we're seeing in the home.
One more question?
Matt.
I was just wondering if the home-based primary care teams currently or in the future will have nutritionists that go to the home. Because I feel like a lot of like heart failure folks are like, oh yeah, I got some soup.
Yeah.
Just went to the pantry, like, yeah, all this is bad.
Yes. The question was whether or not, currently or in the future, would nutrition be involved in home-based primary care? Because I can agree. When I went to see Mr. R and I asked him permission to open up his fridge and cabinet, and there were things there that it was just all bad. So I will say I'm not quite sure if a nutritionist is being in terms of the home-based primary care team at UW that's going to launch in the fall, what that is specifically is going to look like. But I will say most home-based primary care teams in the country, and definitely at the VA, involve nutrition because I do think that's an important piece as well.
Thank you very much.
Thank you.